Good morning, everyone, and welcome to the session Born Green Generation, Delivering Toxic-Free Healthcare. In this session, we will hear more from experts in maternal and pediatric care about the importance of minimizing the healthcare environmental impact for the most vulnerable patients, particularly over a critical period for child development called the first 1,000 days. Before introducing our great speakers, a couple of quick points from me. First, please note that this session is being recorded and will be available on this stage shortly after the session has ended. Second, please use the live chat tab in the panel to the right of your screen to add any comments or the Q&A tab to send questions to our speakers. Please specify who your question is for, and we aim also to put them to the speakers. If we don't have time to answer any question, then speakers are encouraged to answer them in the chat after the session. Otherwise, please feel free to engage directly with the speakers through the platform who below. Now, I would like to guide you through the content and format of this session. The title of the session is also the title of Healthcare Without Harm Europe new flagship project, Born Green Generation, Delivering Toxic-Free Healthcare. And you can find the link of the project, the website in the chat. We're working with healthcare providers, university, and many relevant stakeholders to promote a model of maternity and pediatric care that protects current and future generations from the health and environmental harm caused by toxic chemicals and unnecessary single plastics used in healthcare. So we'll hear from our first speaker, Josephine Frame, who is a practice development midwife at Lewisham and Greenwich NHS Trust. Her clinical perspective on the importance of reducing environmental pollution during pregnancy and perinatal care, and the practical steps that can be implemented to achieve this goal. Then we will hear from Elena Codina Sampera, who is a pediatric nephrologist at Sant Joan de Déu Barcelona Children's Hospital. She has a strong interest and is engaged in different initiatives related to environmental health and in this area, and she's also part of the steering committee of Born Green Generation, and she will talk more about her perspective as well as vision for pediatric environmental health units. Finally, we will hear from Charlotte Adams, who is Sustainability Delivery Project Manager at Great Ormond Street Hospitals, who is one of the Born Green Generation project partners. And Charlotte will present Born Green Generation and the steps taken so far in their Koala unit. We would like, as I said, we would like to leave time to answer questions from the audience at the end of the session. So I really encourage you to use the Q&A tab to send questions to our speakers. Okay, so let's get started. Jo, the floor is yours.
Thank you very much. I'll just bring up my presentation. So good morning. It's a pleasure to be joining today. As mentioned, my name is Jo. I'm a midwife based in Southeast London. So as a midwife, health promotion is at the core of our practice. And for women and birthing people, the peripartum continuum is often the time where they have the most regular contact and frequent contact with a healthcare practitioner, especially for those who are, for the most part, well and healthy, and they don't need to go and see healthcare practitioners for pre-existing conditions. So today I'm going to be talking a little about the impacts that the climate change is having on the health of the pregnant woman, their fetus, as well as some elements of midwifery care, which is already standard care pathways that add in a green lens. And I'll also be talking about potential opportunities within maternity services and a couple of case studies. So many of us will be familiar with this graphic, highlighting the impacts that the climate crisis has upon population health and how adverse weather events exacerbate them. However, it's important to remember that these impacts are limited to the adult population or even the child population, but it starts from in utero. We know that people from more deprived areas of society are impacted most by the impacts of climate crisis, and women and children more so. If the pregnant mother or birthing person is suffering from any of these conditions, it can also affect the fetus in utero as well. So, excuse me. So the first 1,000 days, it starts from the point of conception, right So this is where the element of care from midwifery and obstetricians is key. And there's a huge breadth of research highlighting the impact that the climate crisis is having on pregnancy health. And here is just some of the risks that are associated. So there is an increased risk of infertility as a consequence of rising climate, rising temperatures, and poor air quality. That's impacting ovarian reserve and spermatogenesis. Also, a decreased sperm motility. So this is already highlighting that it affects the conception of an infant beforehand and the impact that that can then have on care providers in supporting families become pregnant. And then as well during the pregnancy, there are further impacts such as exposure to high temperature in the second and third trimester can equally reduce the birth weight at the time that the infant is born. Similarly, it impacts the placental function, and that is literally the lifeline to the fetus in utero. So if there are issues such as poor air quality that are affecting maternal health and maternal respiratory and cardiovascular conditions, then that's also going to impact the infant as well. High temperatures in the 21st and 22nd week also increase the risk of gestational diabetes, more prone to infectious diseases and chorioamnionitis, which is infection in the uterus of the amniotic fluids. Similarly, as highlighted above, due to placental function being compromised, that can also result in low amniotic fluid, and this helps to mature not only the gut but the lung and respiratory system for the fetus in utero. So if we're having all these issues for the health of the fetus, then that is not only going to place an increase in demand on the maternity health service, but there's also evidence showing that a rising climate, a rising temperature, and increase in poor air quality and adverse weather events, the stress and anxiety that can be led to from that, including the PTSD, they are all potential risks to preterm birth as well as intrauterine growth restriction. Those situations are then likely to require more intensive care of the neonate, potentially requiring neonatal NICU admissions. And that places even more burden on a healthcare service, but also potentially increases the exposure of the infant to single-use plastics, more equipment within the healthcare service, more products and more medication in order to support their ongoing development. And just on the left as well, here in the UK, we have a report called the Embrace Report, and this is a confidential inquiry into maternal and neonatal mortality and morbidity. And for the most recent report, it did show that after COVID-19, cardiovascular disease and blood clots were the two leading causes of death for pregnant women and postnatal women over the last triennial. So here, unfortunately, this video is not going to work today, but I do urge you, I'll put the link in the chat, and I do urge you to go and look at it. So Maria Kojic is well known for the video that she made of all the waste that was produced from her own surgery. This second video that she produced, called My First Little Footprint, highlights all the single-use products that were utilised during a birth of an infant. And this is not just exclusive to the healthcare system in her country, but can be replicated throughout the world as well. And one thing that this really made me reflect on, and having discussions with colleagues from overseas who have worked in healthcare systems where potentially everything has to be itemised, either for billing or just due to lack of resources, was just this really highlighted how disposable products are perceived in some countries, including here in the UK. So in Here in the UK, the NHS was the first national health service to commit to a net zero ambition. And the publication of Delivering a Net Zero NHS outlined the ambition, the key areas of high carbon output, and also highlighted some areas for focus, and as well as the ambition to reach net zero. On the back of that, in 2022, net zero care was embedded into the Health and Care Act. And then wider, we have got many colleges which now have sustainability plans embedded, as well as each trust and healthcare services within the NHS has a net zero commitment and a green plan in place. More recently, the Care Quality Commission, which is our regulatory body of healthcare providers, they have incorporated sustainability into the well-led criteria for their framework. And many of the professional organisations, such as the Nursing Midwifery Council, have also made a step towards including sustainability, not only into their own operations, but into the expectations of clinicians moving forward as well. So in the UK, one case that I wanted to highlight is something that is already pre-existing here in the UK, and that is the smoking cessation. So we know that stop smoking during pregnancy is the single avoidable action that can significantly reduce the risk of intrauterine growth restriction and stillbirth of the fetus as well. So the public health role of a midwife is to conduct the initial carbon monoxide screening at booking, perform a referral where appropriate, and ensure that there is enhanced monitoring. So that is not only that ongoing support of the mother and potentially wider family in achieving stop smoking, but also monitoring the growth of the fetus. So potentially an increased frequency of ultrasound scans and Dopplers to check on the placental function and the growth of the infant as well. So if successful, that intervention means that there's reduced risks for the preterm birth, potentially avoiding in utero transfer to a tertiary unit as well, and reduced risks of NICU and SCIBU admissions. So reducing further service demand by the family stopping smoking once the baby is born and discharged home. There is also reduced risk of sudden infant death syndrome as well. And as there is a reduced chance of that infant being preterm, that means that we have got a reduced chance of infant separation at birth, which in turn increases the potential for successful breastfeeding establishment. And then the health impacts and benefits, not only the breastfeeding can have, but then due to the no further smoking in the home, then that significantly reduces the risk of that child developing asthma later in childhood. So I really enjoy this care pathway because it is something that is already existing, but this just gives the opportunity to highlight not only the direct impact it is having on that pregnant person or mother at the time, but also the positive outcomes that it is having for the infant, the reduced pressure it is putting on the service in the near future, but also highlighting the benefits that it has for that child for future health as well. Other things that are happening in the UK as well is considering climate smart care pathways. And this is just one example of hypertension monitoring in pregnancy. So women or birthing people who develop hypertension or already have it pre-existing, this can really can significantly affect the placental function as any blood pressure issue can. So it is standard practice that these people will have enhanced monitoring and more frequent monitoring of their blood pressure and fetal growth as well. So in this case study, down in southwest England, they have introduced a remote hypertension monitoring. So women are given a personal blood pressure monitor, and utilising an app, they can monitor their blood pressure at home. And if there are any abnormal readings, that's when they would be referred to either the day assessment unit or the triage. So by considering the climate smart pathway, it's not, again, it's reducing potential clinic appointments, which the blood pressure monitoring would have occurred face to face, but it's also more convenient for the women. It is reducing the need for travel. And then the impact that it can have on that care component is that of saving, it was the whole process, it was process mapped and carbon footprinted at this particular ICB, and saving over 22,000 kilograms of carbon dioxide equivalent in the space of 12 months. And that's equivalent of driving 4 times around the equator, which is phenomenal. And that's just in one trust where there were 83 service users of this particular pathway. Similarly, thinking about circular economy and the infants themselves, we know that breastfeeding has significant health benefits for both the infant and the mother. But if people either choose to use formula milk or they need to for clinical reasons, then of course we support them in that choice as well. So in my own trust, the infant feeding lead introduced we generally used single-use feeding bottles and single-use teats as well, 100 ml volumes. And for those who aren't aware, that for a neonate that is just born, generally the size of the stomach takes a maximum capacity of around about 20 millilitres as well. So the fact that we're using these single-use 100 millilitre bottles, the volume, the plastic is significant. But then we know that these families are potentially going to be going home using their own feeding bottles as well. So by introducing sterilising equipment on the postnatal ward, it meant that these families were then invited to bring their own products in. They were able to be educated and empowered onto how to sterilise and prepare milk safely whilst on the ward. And then by doing so, there was also a significant cost saving as well. And just within this one postnatal ward, here are the projected, this is still underway, but the projected savings there, which is the equivalent of driving London to New Delhi. And as I mentioned, thinking about the volume of the infant's stomach, by reducing what is already procured to a smaller bottle would significantly reduce the carbon footprint again. Similarly, over in Isle of Man, they're not part of the NHS. They have their own healthcare system as an independent state. But in 2004, they introduced reusable cloth nappies, and they have roughly 600 births a year. And from the maternity services, their clinical waste reduced by 90% by introducing this small intervention. So 95% of service users utilise these while in hospital. And it's estimated that over 144,000 disposable nappies have been avoided since the introduction. And again, thinking about the nappy itself, various products on the market, but generally it takes, for one single-use nappy, it can take around about 400 years to decompose. So if Elizabeth I here in England was utilising disposable nappies and they were placed in a landfill, they would not yet have disintegrated. Just to give some impact to magnitude to the impact that they have. So similarly, in Northampton General Hospital, they are working with the Nappy Alliance here in the UK and a local manufacturer of cloth nappies. So they are currently going through a education phase for their staff and a pilot of training to empower them to have supportive and suitable conversations with service users and expectant families around about nappy options, just as we do with infant feeding or any care options as well. So they have this plan, and then, oops, sorry, I thought I had another slide there. But ultimately, the ambition is to also introduce cloth nappies within their unit as well. So that's just a few examples and some opportunities here to get involved from various networks, and the Greener NHS Knowledge Hub is has phenomenal resources as well. And I just want to finish with the Venn diagram in the middle of finding what brings you joy, what work needs doing, and what you are good at can be just the starting point of making a difference. Thank you.
Hi, Joe. Thank you so much for this presentation and also for providing these practical examples and steps that can be taken already to reduce exposure to environmental harm and these items. So from a midwife to a pediatrician, I'd like now to give the floor to Elena and hear more about her experience in this topic.
Thank you very much. I'm sharing my screen. Yes. Yes. Good morning. I'm Elena Codina, pediatrician and head of the Pediatric Environmental Health Unit at Sant Joan de Déu Hospital, a pediatric hospital in Barcelona. I'm very excited to be able to participate in today's meeting, and I would like to thank the organization for inviting me. Let's start talking about what environmental health is. It's a discipline that has been studied for years in other parts of the planet and which will come to be defined as all those environmental exposures that have an impact on the health of a child and that will have an impact for the rest of their lives. There is a concept called exposome, very well defined by the Global Health Institute of Barcelona, in which health is defined by as the sum of three different spheres. We have a biological base with our genetic disposition, and on top of that, there will be two spheres, the external exposome and the personal exposome. The external exposome, for example, would be defined by the environment in which we live, whether urban or rural, the atmospheric and acoustic pollution we are exposed to, what degree of connection we have with nature, and other external factors. And on the other hand, there is the personal exposome that could come to be the lifestyle we lead, that is to say, the physical activity we carry out, what kind of food we eat, what social relationships we have, what toxic substances we are exposed to, etc. The World Health Organization recently published an infographic to express its concern about the increasing pollution of the ecosystems where our children are born, play, and grow. The concern focuses on air pollution, the effects of climate change, exposure to tobacco smoke, and the materials used, for example, in construction, which are increasingly toxic to our health. They also refer to two emerging entities, such as the endocrine disruptors and the e-waste management, that is the management of waste from electronic devices. We pediatricians always like to remember that children are not small adults and that they have physical, biological, and behavioral characteristics that make them particularly vulnerable to the possible toxics in their environment. First of all, we can say that their entire body systems and organs are immature and therefore will not have the ability to face those external pollutants as an adult. They breathe more times per minute than adults, they eat more food per body surface, therefore the intake of these toxics will also be higher. Children are curious, so they touch everything, and many times they put things in the mouth without thinking if they could be toxic. The small stature of children also means that they are more exposed to inhaling toxins because they are closer to the ground, and on the other hand, they are also closer to car exhaust pipes. And finally, there are two particularly important characteristics. First of all, they cannot decide not to be exposed to these environments. Therefore, it's our responsibility to protect them. And in addition, they will live many more years exposed to these polluted environments. So we do not know which consequences this may have in the future. It's also important to keep in mind that this vulnerability starts from the preconception period and is very, very important throughout pregnancy, as you can been listening before. Here, what I want to emphasize is the importance the effects of climate change will have on our health in the coming years. We know that there has been global warming since the pre-industrial era, and this warming will lead to an increase of the frequency of extreme climate phenomena, and that will have a direct effect on our health. This warming will depend on the ability we have as a society to slow down the combustion of fossil fuels, even though we now know that at least 1.5 degree warming is guaranteed. As health agents, we must position the policy to stop consuming this type of resource. In this systematic review that was published in the New England Journal of Medicine, we can find the impact and the relationship between the combustion of fossil fuels, climate change, and the effects they will have on the pediatric population. To sum up, we must give importance to the concept of planetary health because without a healthy planet, we will not be able to have healthy childhoods. Furthermore, not only the combustion of fossil fuels is the source of global warming, but it is also used to manufacture plastic materials, and that is the main problem we have to preserve planetary health. In addition, global plastic production, as you can see in this bar chart, year by year continues to increase, and therefore it will also be one of the main aspects we should focus in order to stop the worsening of our health. And what can we do as pediatricians and health professionals? I will explain a little about the evolution and origin of the Pediatric Environmental Health Unit. The first Pediatric Environmental Specialty Unit was created in 1998 in the United States with the support of the World Health Organization. These clinical units are usually located in hospitals where pediatricians specialized in environmental health work together with other health professionals and with professionals from other fields as well, such as architects, engineers, and chemists. The main objective of these units is to provide assistance to patients and group of patients who require it, and then to shape health professionals in environmental aspects, research, innovation, participate in local, regional, or national policies, and also to promote health and environmental health knowledge in the community. These would be the units that currently exist in the United States. Here in Europe, and specifically in Spain, there is the unit of Arrixaca's Hospital in Murcia, the unit of Olot's Hospital, and the one in my hospital, Sant Joan de Déu, in Barcelona. The unit was born with the aim of incorporating environmental health in a very transversal way inside the different services and departments already existing in the hospital. We like to believe that it is the way to see our practice from a more planetary perspective. Our areas of action would be research, teaching, health promotion, environmental sustainability, and above all, assistance as our main aim. At the healthcare level, we have two work tools: the Pediatric Environmental Health History, which we use in these groups of patients that you can see in the presentation, and the Green Leaf, which is a way to screen environmental health in newborns and in pregnant women. As we mentioned at the beginning of the presentation, endocrine disruptors are a public health problem of growing concern. We find substances considered endocrine disruptors in many of our daily activities. They act at very low doses, They have additive or synergistic effects, and in addition, they can accumulate in our body and manifest their effects after a few years or even in future generations. In our daily pediatric care practice, we find plastics and endocrine disruptors everywhere. For this reason, it's important to work together in research and innovation to find new materials that can replace these plastics. Sessions like today's help shape the path in this direction. At the hospital, we are aware that there is still a long way to go, but we are currently working on the surgical area to find ways to reduce the use of plastics in pediatric operations. And on the other hand, we are working on how we can eliminate all the plastic bottles that we use on a daily basis in the hospital. We are working on this together with the patient experience department, and we believe that this will be a reality within the next few months. We are also working to advise on the avoidance of endocrine disruption in pregnant women and in patients with early puberty. Thank you very much for your attention. It will be a pleasure to answer your question at the end of the session.
Thank you very much, Elena. This was very, very interesting, and it's really a pleasure to hear from you, and also the initiatives that you are implementing in your hospitals. So I'd like now to encourage again the audience to write their questions in the Q&A or in the chat. I see that some are coming through, and also speakers are also starting to answer those. So please continue. And now I'd like to invite to the stage Charlotte, who's part of the Born Green Generation project with Great Ormond Street Hospital, and we'll talk more about their experience with that in their koala unit. Charlotte, the floor is yours.
Thank you, guys. I'm just having some issues sharing my presentation. So I'm just wondering if somebody else might be able to share that potentially, but I'll make a start anyway. So we are taking part in the Born Green Generation project that was spoken about now. So there's kind of a 3-pillar approach to this project. So the first pillar is innovating practice. So this is looking at eco-maternity wards, neonatal and paediatric units within European hospitals. And the first kind of innovating practice is looking at business cases to support the model and kind of what innovation in general in terms of sustainability that we can implement within these units. The second pillar is around transforming policy. So this is looking at how we can look at our policy within the hospitals, the policy making, our strategies to make real change in our day-to-day within the hospital. So this might be looking at EU chemical legislation, national legislation by government, local legislation. Obviously within the UK we have Greener NHS, we have the CQC, and understanding how we can work with these groups to transform and move forward policy within these areas. And then we have shifting culture, which is really looking at education and behaviour change and understanding how we can make those changes on the ground to make big changes within our organisations. So if we look at Great Ormond Street, we have quite a good baseline, I think, for kind of our shifting culture. We have committed to reaching net zero carbon for areas in our control, for scope kind of 1 and 2 by 2030, and areas outside of our influence, so scope 3 by 2040. And we also have a kind of above and beyond principle, which is looking at sustainable business practice that will be put in place so that our people find it easier to make the right choices, and sustainability will be the centre to our purpose. So this is really understanding that we can't care for our children if we don't protect the environment that they are being raised in and that we are providing their care in. So we have 10 programme of work areas, and these are really laid out through the Green Plan, which some of you I'm sure are familiar with. So this is looking at procurement and circular economy, travel and transport, food and nutrition, public realm, adaptation, medicines, and really understanding what we can do within the hospital, within these areas, to make positive sustainability changes. So this might be kind of in terms of adaptation, understanding what the local plan within our community is and what our flood risk is, putting in kind of planning for future so that if we are having frequent weather events that are stopping people coming into the hospital for work, or patients coming in for travel, how we can move around that. In terms of community and public realm, we've been looking at something called a healthy hospital street. So this would be pedestrianising the street in front of the hospital to make sure that it's friendly and safe for our patients and families that are coming to visit us, as well as building a community area for the local community around us. We've also been working collaboratively with key stakeholders in sustainability to create podcasts and events to showcase the importance of linking sustainability and climate with health, and that it's a health emergency as well as a climate emergency. With our food, we've been looking at becoming more plant-based with the food that we're offering, instead of such high intensities around meat and all of those kind of things as well. We've also done some quality improvement projects, which I'm sure a lot of you will be aware of, the Gloves Off project. So we undertook this in 2018 and ensured that the project kind of had the triple bottom line. So this is making sure that it is financially doable, it's taking care of our people, and it's taking care of the planet. So this looked at kind of the use of non-sterile gloves and understanding whether they were necessary within the hospital setting and whether we actually needed to use them. And it led to a reduction of 21 tonnes of gloves being used every year, and over a £100,000 financial saving, which is massive. And it also came out in a study that it's a lot better for nurses' hand health to not be using gloves. So it was really beneficial for everybody that was involved in the project. We have also recently done a capsule kids project with our pharmacy team, understanding the benefits of moving from IV to oral medication. So we were previously aware from a kind of research piece we did around paracetamols that it's a lot more cost and carbon effective to have a tablet form of paracetamol than it is to have an IV form of paracetamol. And it's also a lot less intrusive for patients. There's a lower risk of infection because we're not putting a cannula in them. So we kind of wanted to understand whether there was a bigger carbon saving, financial saving, etc. with other forms of medicines. So 2 of our pharmacists undertook a short pilot of this over a couple of months to understand what this might look like. So for 6 weeks supply, of cotrimazole, which I'm sure I've mispronounced, we found that there was a 326 kilogram carbon saving a year, which is the equivalent of 972 miles in an average car, and just over 250,000 financial savings. And it's also a lot easier and nicer for children and adults to be able to take a tablet instead of having to have an IV. They'd normally have a longer expiry date. There's less packaging, less plastics. So it was better all round, and we're looking at kind of what other drugs we can look at to assess this and how we can move it forward within the hospital. On Koala Ward, which is the ward that we are basing our Born Green project in, we looked at the reuse of enteral feed hanging bags for all eligible patients for up to 7 days. So the outcome of this was really successful for the reusing bags, and it's anticipated that there'll be a reduction of 16,000 bags, which is 75% of the bags on this ward alone. Across the hospital, there could be another 75% reduction. So we're looking at potentially 48,000 bags per year being reduced within the hospital, which is amazing. And that will be a carbon saving of 193 kilograms of carbon per year, which is the same as 570 miles in an average car. And in our research on the ward, 100% of our nursing staff surveyed on the ward said that they were concerned about the environmental impacts of the products that we were using within the hospital, and that they were really on board with kind of new initiatives on the project, which were really, really useful stats to understand. And then we also looked at developing a walking aid reuse scheme within the hospital with our physio team. So this was kind of understanding, I guess, how we could bring back our walking aid reuse and reuse them. So I know this is an issue that a lot of the NHS face, is getting back walking aids once they've been given out, and tracking them. It's kind of a tough feat to look into, but we had a really positive result. So we found that by doing this, we could save, in terms of carbon, 1,600 kilograms of carbon, which is a massive amount of miles driven. So it's 4,725 miles in an average car, which is massive. And staff wanted to see more around walking aid returns and reuse, but they were unsure how to do this. So we started working with our neighbouring hospitals within the area, such as UCLH, to understand how we might be able to do a married up approach with that. So kind of working on the projects and the quality improvement that we're already doing in the hospital, we really wanted to understand how we could manoeuvre this into the Born Green project and how we could really excel forward. So our objectives that we've come up with as a hospital are to reduce the amount of harmful plastics used on Koala Ward by 2026. So we're aware that, I think that the stat is that we have or consume around 5 grams of microplastics a week. So that's about 1 credit card's worth of microplastics a week. So we're consuming around 52 credit cards a year of microplastics, which is ridiculous amounts of plastic. So just by trying to reduce the amount of harmful plastics that we're using and putting into our waste systems, we're hoping to lessen this statistic as we move forward. We really want to raise staff's awareness on the ward about circular healthcare, the use of plastics and how harmful they can be, by 80% by 2025. We're doing this by putting together a survey that we will ask staff to fill out intermittently throughout the project to understand their baseline understanding of sustainability, plastics, and how harmful they can be to our health, and to continue to do this along with our education sessions throughout the time period of the project. So we've got a good kind of database to understand how people's understandings are changing, and what they are doing on the ward and how that is changing as the project goes on, and to embed sustainable procurement practices, integrate Ormond Street's hospital, preparing us to reach our commitments on scope 3 as well. So really trying to tie it into our overarching goals on sustainability, and to publish our work with Healthcare Without Harm as well. So our first steps have been to baseline. So we've done a plastic audit on the ward. So this is understanding what plastics are in the playrooms, the staff kitchens, in the wardroom themselves, to understand like what the beds are made of, tables, etc., etc. So we can get a full picture of what the ward currently looks like, as well as the pharmacy list for medicines and all of those kind of things. So we can have a good understanding of what our start point would be, really asking those questions. What are they made of? Is it a hazardous plastic? What are the alternatives? How does this affect our carbon footprint? What's the country of origin and what's the cost? Our next steps are to hold meetings with the teams, understanding what they think the most vital points are that we should start on. So whether that's looking at how we administrate medicines, what our waste processes are, and really understand kind of the benefits metrics of that and what we can do to move forward. But we've got really good staff engagement, and we're really excited to see where the project goes. Thank you.
Thank you very much, Charlotte. It's really a pleasure to have Gosh in this project, and also to learn from your experience with this. I try to keep track of the questions received both via the chat and the Q&A. So we have a few coming in. I will start with a general trend about exposure to or relationship with greening, green spaces, and access to green spaces, or prescribing to prescribing this. So I will invite you to check the chat about that. There are a lot of resources that have been shared already, and feel free to continue the discussion with the speakers about the topic of green prescribing, how now it can be helpful, especially for these most vulnerable patients. Moving on to other questions, there is one from Naveen Kumar. That is, I think it's related to, it's addressing Joe, but if anyone else wants to answer to that, is about the acceptability of reused nappies for other children by their parents. So if you can share any feedback on this, Joe, about the reusable nappies used in the maternity unit and acceptability from parents. And I will also invite the rest of the speakers to come on stage now for the Q&A session.
Yeah, I think where it has been embedded in Isle of Man, so that is an island just off the coast of mainland England. So the fact that they have over 95% usage from their service users shows that there is like an acceptability. Generally, it is processed just like any other hospital linen. So basically, we know that there are linens that are utilised in birth and maybe in A&E services that are exposed to all kinds of bodily fluids, but they get cleaned to the relevant standard and process, and nobody raises questions about who has previously had some bodily fluids on these bed sheets. So there is acceptability, and I think in the general population there is certainly a growing trend in utilising cloth nappies, and a lot of them are purchased secondhand as well. So I think a lot of people initially, it may be either a second child, a third child, or maybe a friend or relatives previously used nappies that they're initially more accepting. But yeah, there is a huge community that sells and reuses, myself included, cloth nappies, and I think that kind of social acceptance is where it's showing that it is more acceptable within healthcare settings as well.
Thank you. And there is a follow-up question, Marianne, that I think you started already to address. It was about how they're processed. So if it's on-site or by suppliers, is this, do you?
Yeah, so here in the UK, every trust has different processes for their linens. Some have on-site laundrettes, in which case they will be processed locally, but those who are maybe part of a larger laundry service that is done remotely off-site, which many of our trusts are, that is where it becomes a bit more challenging. So there are different areas which are even for gowns, for scrubs, for other linens in the trust that they're wanting to keep specifically for their trusts. The wider team behind the scenes and with estates are kind of exploring options. So there are some that do have on-site laundering services, and that's where it's most easily accessible as well.
Yeah, I can imagine. I think this is a challenge at a lot of hospitals now, that in general with textile we want to move to reuse, and indeed finding the providers that can help them with that if they don't have the laundry service inside is a challenge. This is a question that was asked to Elena, but I think it's also interesting for the other speakers because we heard a lot about raising awareness and training. Elena was asked to share more examples of the teaching and trainings that are designed as part of the pediatric environmental health unit, but the follow-up question was also if it's something that is part of the regular curriculum of medical students or if it's an add-on. So if you can elaborate more on that, Elena, and also the other speakers to share your opinion about training and whether this is part of their current curriculum.
Yeah, it's very important for us because I think it happens everywhere. That one of the main objectives is that the pediatricians have the knowledge and why we are going to change our practice, no, in our everyday. So we have organized a training day for primary care pediatricians, because they are the first step on our child. No? We do regular training with residents also, and it's very important because during 4 years, for us, it's very important that they can change no, their view of the pediatrics practice. And at the university, we have started this participation, but it's not a regular curriculum. It's a voluntary training, but we have done it for 3 years. So it's important, no, that in some years we have got 10 generations already formed or trained on this discipline. But I think that in a very few years, it will be a regular formation or training at the university. I hope so.
Great. Charlotte, from your side?
So we currently have a survey out in the hospital at the moment asking clinical staff if they have been educated on air quality, if they're having conversations with patients around air quality, where they get their information from, if it was from their clinical studies, if it's from wider research and those kind of things. So hopefully once that's done, we'll have a kind of wider data pool to understand which is what in that sense. But in terms of like general sustainability, as far as we see, it's not something that is incorporated into clinical teaching at the moment in university, but it is something that we're working with our practice educators on, so our allied health professional educators and our wider nursing educators within the hospital. We will work with them when we get placements in to incorporate sustainability. So the general sustainability and the commitments that the hospital is doing, and then kind of more specialised structures around the specific ward or specialty or area that the students are looking at and understand what that will look like. So that's been really, really useful, and we've had really good feedback from students on that. So that's been really positive as well.
Great, thank you. And Jo, do you want to add anything on that?
Yeah. So I was fortunate enough up until recently to be doing a sustainability fellowship at NHS England, so within kind of like the head office of the NHS, you could say. And within that, focusing on sustainability specifically for nurses and midwives, we as a team set up a national network, and through the wider Greener team as well, there's been a lot of work done As I mentioned earlier, including environmental sustainability into some of our CQC assessment strictures. So again, it's building that awareness and that expectation both at individual level who've got the passion, identifying those early adopters, as well as highlighting to our key leaders, like this has to be business as usual, this has to be on your agenda. And then by doing that awareness, it is kind of starting to shape the education platform as well. So I've had the honour of, with a few universities, presenting to a few cohorts of student midwives who are doing perhaps an excellence in care module as well. So making sure that they consider that as part of any QI proposals they're drafting. We do have nationally a free module that is available on our eLearning for Healthcare platform as well. And then one thing that I'm hoping to do more locally is any modules of mandatory training within the trust, such as medicines management or medical gases, incorporate that sustainability into things that are already existing. So if we're talking about medical gases, let's include a few slides about the impact of some of the medical gases, like gas in air, for example, as a midwife, the impact that can have, and within the medicines management, IV versus oral medications and the impact that can have as well. So yeah, making it tangible to what clinicians are actually doing.
Great, that's wonderful. And adding on that, we can see at Health Europe that this is really an area to work on. There is a lot of interest in circularity and sustainable healthcare. So we developed a circular healthcare training, different modules that have been available in person events to our members, but are also now online. And some of these sessions are also translated into Spanish, French, Dutch, and other languages. So I encourage you to have a look on our website. But also as part of Born Green Generation, we are developing an academic course, elective academic course for together with two university for healthcare professionals, for students. So there will be the workforce of tomorrow. So we can start to embed this in the traditional curricular, even as an elective course. So it will be great to continue to collaborate on that with everyone who is interested in increasing the education on these topics. So we are almost at the end. We only have 2 minutes left, and I would like just to highlight one question, Charlotte, if you could answer then in the chat about IV to oral. At what age you can start to implement that with children, and maybe to also the acceptance, but also the more technicalities of the emission calculation. So that would be very useful because it's a very interesting best practice in terms of reducing emissions. And also improving care. And yeah, I'd like everyone on the panel, starting from Elena and then Charlotte and Joe, to give just one recommendation that you like to the people at home who are listening and who like to start working on this topic in these units. What is your recommendation or key message for them?
Shall I start?
Yeah, please.
Each small change is an important change, because the mountain is very high, but we must start with the small steps.
Great, thank you. Charlotte?
I'd say collaboration. I think don't reinvent the wheel when people have already started on projects and have kind of done all the hard work and implemented things already. It's such a tall feat to kind of conquer all of this. So it's definitely, I think, a teamwork approach on this, and just to share and collaborate where you can.
Thank you. Joe?
Basically reflecting both of those, that if everybody just make one small change that they can commit to every day. There are 80 people on this call, so if we all commit to like one less pair of single-use gloves, then that's 29,200 pairs of gloves that aren't utilised. And yeah, reach out, find your tribe. Yeah.
Indeed, I would agree with that. So thank you to all the speakers. We've come now to the end of this session. Once again, thank you so much also for the audience to stay with us until the end. And we heard a lot of concrete examples about sustainable practice in maternity and pediatric units. So I hope this will be inspiring and can be implemented also in your daily work. So we invite you to keep the conversation going via the chat box or connect directly with our speakers and fellow attendees via the platform. Coming up next at CleanMed Europe, we have the workshop Reducing the Environmental Footprint from Operating Theatre, which will begin at 12:30 Central European Summer Time. And I also would like to highlight another session we have coming up on Tuesday. Tomorrow at 3:30, we'll have infection control and sustainability, a reciprocal relationship. This is very important in terms of circularity. We know that we need infection prevention control to support any sustainability work and any practice we want to change in terms of single use. So stay tuned for that. And then on Thursday, moderated by my colleague Akif, there will be at 10:45 a session on plastic alternatives or a safer future. As well as a great workshop on chemical procurement criteria, presenting our European phase-out list, which will begin at 5 again on Thursday. Many thanks, and we hope you enjoy the rest of CleanMed Europe.